entrapment neuropathies. Now, there are radiculopathies. Let's talk a little Latin and Greek. Radiculo is a combining form that means root. And anything with radiculo refers to where it comes out of your spine, the nerve root. Pathy means pathological or abnormal condition of. Neuropathy means, neuro means nerve, abnormal condition of the nerve. Peripheral neuropathy is, as opposed to radiculopathy, there's peripheral neuropathy. So you can have an entrapment neuropathy, technically speaking, when you have an HNP at C5-6 hitting the nerve, you're entrapping it. But we're talking about peripheral entrapment neuropathies. So we also call these compressive neuropathies in many cases. And I'll use different terms because I'm not sure how you'll encounter them in your travels. But they're the same thing. Compressive entrapment. So let's start with the upper extremity. Can you name a compressive neuropathy of the upper extremity? The most common compressive neuropathy of the upper extremity? Carpal tunnel. Perfect. Whoever said that. Carpal tunnel is a neuropraxia, properly spelled with an A, not an O, but you'll see it with O. Neurapraxia. There are 3 degrees of nerve damage. I have that, I think, in Principles of Orthopedics, so if you want to look at that, you can. If you want to write it down, you can. But the least serious and almost always self-limiting is neuropraxia. That is a temporary condition. That is the typical carpal tunnel syndrome patient that has been driving too long and they are compressing their hand on the steering wheel. They develop a nerve injury. Remove the offending insult and it will heal. The next most serious, going in descending order, is something called axonotmesis. A-X-O-N-O-T-M-E-S-I-S. More serious, some damage to the myelin sheath, but it can still heal, but it will take longer. And the most serious nerve damage level is called neurotmesis. N-E-U-R-O-T-M-E-S-I-S. N-E-U-R-O-T-M-E-S-I-S. It is typically not going to reverse. It's a cutting through of the nerve, essentially. It's common after lacerations, for example. Somebody's working in their garage and they just got a brand new buzzsaw, and before they learn how to use it, they use it, and the rest is history. You'll learn more about that kind of injury in emergency care of 7th semester with me. So fortunately, almost all of the compressive neuropathies that you're going to see in your clinic are going to be neuropraxias, and the foremost of those is carpal tunnel syndrome. That's also known. What nerve is involved with carpal tunnel syndrome?
Median.
Median? You sure?
Ulnar.
You're correct. It's median. Stick to your guns. Stick to your guns. Yeah. Median nerve. After I do this,
It does do that.
Thank you though for going out on a limb. I admire that. You know, I'll mess with you like that over and over, and by the time I'm done with you, you will be. What do you mean? Am I sure? You'll be. Knock it off, Dr. Priest. Of course I'm sure. Wouldn't have said it if I didn't mean it. Mean what you say what you mean. But of course now you're still learning. So median compressive neuropathy at the wrist is carpal. That's another fancy pants name for carpal tunnel syndrome. It's very descriptive. Carpal tunnel is composed by the bones on the dorsal side and by the flexor retinaculum, a fibrous band on the what's called the volar surface. Here's another word for you. There's an extensor surface and a volar surface. Volar is the flexor surface. So this is the flexor surface of my forearm. It's the volar, V-O-L-A-R surface. So there isn't a whole lot, if you were to cut my hand off and look at the end of my wrist, there isn't a whole lot of room for all the stuff that has to go through it. There's a lot of SGO, a lot of stuff going on in that carpal tunnel. And what happens is, ultimately, if a patient ends up with chronic carpal tunnel syndrome, the concern becomes that the nerve damage can become permanent. And when we really worry about a carpal tunnel syndrome patient is where we start to see atrophy of the thenar muscles. That is not a good sign. That is time to say, let's get another set of eyes on this because this patient may need surgery. If you wait too long and the nerve essentially dies, no amount of surgery will fix it. And they'll end up with a very clearly atrophied, and you gotta use your thumb. There are 3 muscles innervated by the median nerve in the hand. Intrinsic muscles. Intrinsic muscles of the hand mean the muscles that are from the wrist down, they're in the hand. Like the palmar and dorsal interosseous, right? Pad and dab, right? Palmar adduct, dab, dorsal interosseous, abduct. There's another one of those lovely mnemonics. But those are intrinsics, and there are 3 muscles that are innervated by the median nerve in the hand. APB, FPB, and OP. APB is the abductor pollicis brevis. FPB is the flexor pollicis brevis. Pollicis just means thumb, right? And the OP, which is the opponens pollicis. So they all 3 have to do with the thumb. You can test any 3 of them and assess that median nerve. And I used to do the APB because I found it most dependable, where the thumb's a little weird on abduction, adduction, flexion, extension. It's just lifting the thumb off the palm and resisting. I saw a lot of 3/5 or 4/5 APBs. But most of the time, you know what you're going to see? You're going to see a patient that comes in and says, you know, my hand is tingling. Where is it tingling? It feels like it's tingling in my fingers and my thumb. Which fingers? Sometimes they'll draw a perfect peripheral nerve sensory mapping for you, which is the lateral aspect of the ring finger, the middle finger, index finger, and thumb. Now, I'll just quickly touch on the fact that you can be fooled. There is a superficial palmar branch of the median nerve that goes over the flexor retinaculum. So if the tingling, the paresthesia, which is fancy term for tingling, fancy term. So you want to impress somebody at a cocktail party, say paresthesia. When you're talking to your patient, say tingling. We don't want to impress them. We want them if they understand why they're there, they'll do better. My first 6 months in practice, all I did was try to impress my patients, and they were very impressed with me, but they didn't return because they had no idea what I was talking about. I realized what a bozo I was. They can get a friend for free. They want somebody that'll explain stuff so they can go home and tell that was my goal. Explain to Fuzzy what is wrong with Fuzzy, so Fuzzy can go home and tell her husband or boyfriend or whatever.
Oh, thank you.
If you can explain it, then you got it. So anyway, APB, FPB, and OP, and we'll deal with that later. But those are the 3 muscles involved. You understand now what the cutaneous innervation is, but that superficial median nerve just innervates the palm. So if they don't have it into their thumb and fingers, it's probably not going to respond to a decompression, which is how it's treated surgically. All that happens, tiny incision, whether it's endoscopically, which is all the rage, sometimes it'll be open, but it's a tiny little incision. They'll just divide that flexor retinaculum. Transverse carpal ligament it's sometimes called. Lo and behold, pressure off nerve. And unless there's a permanent change, then they get whatever they lost back. But motor changes are the most ominous for any of these. You want to watch out for motor changes. Don't mess around with motor changes. Sensory stuff, you got some time. With motor changes, if you see atrophy, here's how I evaluated atrophy. I would look at the hand on tangent and compare the two. And if I saw one sunken in, bummer. Typically, it's more common, it seems, in females. Patients tend to be hypothyroid or pregnant. It's worse at night. Patients will tell you, I wake up with my hand tingling so badly that I'm in tears and I have to sit up and shake my hand. They'll try all kinds of contortions. They'll rest it over the side of the bed. I've heard this story more than twice, believe me. And it's a very, very similar story. Hypothyroidism, diabetes is a common problem. One of the things that's common to those conditions is people retain water when they're pregnant. And remember, water cannot be compressed. Air can be compressed. If you're a diver, you know this, but water cannot. It compresses. And so what does it compress? It's not going to compress the bones. It's going to compress the soft stuff. And the soft stuff in a little place like this, women generally have smaller wrists than men, so there's a little less room to start with. So they're a little more susceptible to CT, carpal tunnel syndrome than men are. But men get it. Men get it. A lot of my patients, they had lawn services or they were long haul truckers. So what can you do about it? Carpal tunnel. What you can do about it, first of all, is talk to the patient. Is there any way we can modify your activities to remove that offending insult? If they have a lawn service and they're the lawn person, you can put them in gloves, you can tell them to try to do it one-handed. It's an issue. If they run a jackhammer, it's an issue. But if they're a long haul driver, what I used to tell them is, instead of holding your hands up here for your 600 miles each way a day, put your hands down here. So instead of compressing, you're unloading. And sometimes something just that simple will make the world of difference. Also, there is something called a neutral position wrist splint, sometimes called a cock-up splint. I had a bunch of them sitting around. I don't know why, but I did. And I had so many of them in my office, different types. But this is a neutral position wrist splint. And it has a little metal or solid, almost like a tongue depressor in there that's bent. And what does it do? It just cocks up my wrist in a neutral position. Why? Because that maximizes the carpal tunnel space. So I put them in that at night. I'd say, you gotta wear this at night. If you can wear it at work too, bonus. But if you're not willing to wear it at night, I won't provide it to you. And they, almost all of them, give me two. I'm gonna wear the first one out. Some of them go clear up the forearm. It really doesn't matter. The whole idea, the reason at night I emphasized is, number one, it was easier for them to comply. But that's really not number one, it's number two. Number one is because at night, people sleep like this, which is nothing more than a Phelan test, right? Have you ever awakened with your fingers tingling?
Mm-hmm.
And they don't know it because they're sleeping. So they wake up, oh no, my fingers are numb again. So if we can keep that from happening with this metal stay in there, then we've saved them some trouble, because then when they try to do this, they're going to go, oh, I feel that Velcro. What on earth is that on my face? Oh yeah, you got a brace on. So it's a neutral position wrist splint. It's a brace. It's an orthosis. All right. They are really old. I left a bunch of the stuff with the guy that bought my practice, but I didn't think he wanted my used ones. Patients feel better, and guess what they do? Dr. Priest, thank you so much. Here's mine. Give it to somebody else. And of course I say, that's so sweet of you, of course. But you never give a used brace to another patient. Anyway, so neutral position Risplen, carpal tunnel syndrome, median compressive neuropathy at the wrist. Next most common one in the upper extremity, I would say, would be cubital tunnel syndrome. What nerve does that involve?
The ulnar nerve.
Ulnar nerve. Good. There's not a whole lot of meat between your skin and your ulnar nerve. So people that sit at a desk like this on phones have a lot of trouble. People, it's made worse by flexion because you're now pulling that ulnar nerve through that cubital tunnel, which is your funny bone. And we've all hit our funny bone, right? That's the ulnar nerve. Goes to the ulnar side of the hand, pinky and ring finger, down the arm. It's also something called Guyon Canal Syndrome or cyclist's palsy, but that's at the wrist. Cubital tunnel and carpal tunnel refer to the location of the compressive neuropathy. So at cubital tunnel, it's the ulnar nerve at the elbow. Guyon's canal or cyclist palsy is at the wrist. It's the same nerve, different mechanism. It's called cyclist palsy because these people that ride these long distance bike rides compress their ulnar nerve. And so, of course, they have entrepreneurs. I have one on my bike. They have a hand grip that has like a little flat curved piece under the palm. Instead of it, looking at it from the top, it's kind of like, so then instead of it being like this, when I lay my hand on it, it spreads out the force. So it's not compressing such a small area. Guyon canal is the anatomical structure where the compression occurs, Guyon's canal. Cubital at the elbow. Guyon's canal, you get them, if they're bike riders, you get them to wear gloves, and you get them to go out, if they don't already have it, get that little paddle-shaped hand grip. Okay, cubital tunnel, you can put them in an elbow pad. You tell them not to rest on that elbow. You tell them to try to avoid sleeping with their arm bent up to their face, because again, think of the nerve as a wire, and it's a flexible wire, but it's kind of like a wire. And if you flex, you're tugging that nerve around that cubital tunnel and causing irritation. Treated surgically with something called an ulnar transposition surgery, where all they do is they cut around it and then they move it above that cubital tunnel. They shorten the distance from point A to point B, so it's not so compressed. Tunnel.
My brother had that surgery.
Did he? How did he do? I've seen mixed results.
Yeah, I mean, it's acting up now, but he had it at 15, so it's been about 10 years.
Well, I hope he continues to do better. So you don't want to have that again, I'm sure. It's no fun. Cubital tunnel. So now there's radial tunnel. I'm telling you about radial tunnel. This is probably the single most difficult compressive neuropathy in the upper extremities to diagnose definitively. Because for every practical purpose, it looks just like tennis elbow. Patients will come in, and if they have lateral epicondylitis, it will hurt here, and it'll hurt when they supinate and extend. Well, with radial tunnel syndrome, one of the quickest clinical ways to differentiate is to take 3 fingers, go down about 5 centimeters from the lateral epicondyle, go south, and if it hurts down here more than here, that may very well be radial tunnel syndrome. Another way to tell is if nothing works for the tennis elbow, and here's one of my tennis elbow gel bands. You've seen the Aircast. I like Aircast better. I experimented with these, but I like Aircast much better. I use Aircast stirrups for sprains in the ankles, and I just like Aircast. But it has a bladder in it, little air-filled bladder. And it's so easy to use. What it does, I won't get into this now because we're not talking about tennis elbow right now, but it just creates an artificial insertion. It changes the insertion from the conjoint tendon where it hits the lateral epicondyle, moves it down a little bit, and gives that a rest. Makes it easier for it to heal. That's all these things do, is make essentially an artificial insertion point. What's the most common tendon involved in lateral epicondylitis? ECRB, extensor carpi radialis brevis. Don't worry about that. You don't need to know that now. Just get it in your neurons. Now one pathway's open. We'll open more later. So that is, we've covered carpal, cubital, radial. Radial also, where the compression typically occurs, for part of the radial nerve, it's called the arcade of Frohse. F-R-O-H-S-E. It's just a fibromuscular tunnel. And that posterior interosseous nerve, which is a branch of the radial nerve, goes through that, and it just hurts like the dickens. Again, it's hard to figure it out because there's a certain test you'll learn in semester 7. It's called Maudsley's test. It's the resisted middle finger extension test. Hurts just as bad for radial tunnel as it does for tennis elbow. And then lastly, tarsal tunnel syndrome. Where do you think the tarsal tunnel syndrome occurs?
The foot?
The foot, right? Makes sense. You're thinking, I want you to think. Yeah, it's in the foot. It's the posterior tibial nerve on the medial side of the foot where it curves around the medial malleolus. And there's a fibroosseous canal through which it passes. And when people get flat-footed for whatever reason, which is also known as pes planus, pes foot, planus flat, what happens is if this is my leg, and this is my foot with a normal arch, if I overpronate, what happens to, and that posterior tibial nerve is coming around my wrist and going into my foot and becoming the plantar nerves. If it pronates, it splays out and lengthens. Guess what that does to the wire? Stretches it around that medial malleolus and irritates it. So sometimes that has to be surgically repaired. If the patient can defer surgery, which they usually can, you can put them in a rigid or semi-rigid orthotic to restore that arch, which does what? Takes it from this to this and shortens that stretch on that nerve. Very simple. So those are the major entrapment neuropathies that you're likely to encounter, and some ways you can treat them. Again, make sure you look at my weekly schedules. Just glance at them. There's a lot of stuff. Don't get overwhelmed. It's more of a resource than it is something I'll tell you when I expect you to know it. I just like to give you stuff that you can use as a resource. So now we're going to go back to our slides. I don't know why this clicker seems to peter out for no logical reason, because I changed the battery, but it does this. It's very odd. Any miracle workers, Jeremy? I changed no setting. It worked perfectly earlier, but now it just decides, well, I'm union. I'm not working. But no, it's really weird. I had this happen in this room.
I don't trust those things.
Okay, well, let's go ahead if we could, please, Nan, thank you very much. Let's get going here. The keyboard won't work. So, let's learn the difference between I was trained, I call it spondylolysis and spondylolisthesis. I'll try to remember to call it spondylolysis and spondylolisthesis, but they're the same thing. It's just equally accurate, just creature of habit. So spondylolysis, lysis means abnormal destruction or breaking up. Spondylo means spine or vertebra. So listhesis means slippage. A listhesis can be anterior or posterior. There can be a retrolisthesis or an anterolisthesis. And anterolisthesis is the same thing as a spondylolisthesis. Some radiologists and doctors prefer to call it an anterolisthesis. Some prefer to call it a spondylolisthesis. So, spondylolysis is a fracture. It was formerly considered to be congenital. People were born with this, and they used to call it Jeep spine. They called it Jeep spine because back in the day, in the war, they were bouncing around in these old-fashioned Jeeps that were not known for their shock-absorbing capabilities. And they'd get this, soldiers would get back pain, they'd go to medical and they'd get an x-ray, and they'd, lo and behold, there is their spondylolysis in all its glory. And therefore, since we know that association always equals causation, right? For the sake of the recording, that is what we call sarcasm. But they made that logical fallacy of the post hoc ergo propter hoc fallacy after the fact, therefore because of the fact. They said, well, you were riding in a Jeep, your back didn't hurt before riding in the Jeep, now it hurts. We x-rayed you, you have 2 fractures of your spine, or in that case, at that time, they might have said you were born with this. Therefore, the Jeep caused this. Well, the fact of the matter is, we really don't know if the Jeep caused it. It could have. But a lot of people have asymptomatic spondylolysis and asymptomatic spondylolisthesis. Now let me mess with you a little bit because I want you to think this through. Spondylolisthesis is the slippage. Spondylolysis is the fracture. It's a fracture of the pars interarticularis. You remember this. So can you have a spondylolisthesis without a spondylolysis?
Yes.
You can. How? With masks, I can't see, so I don't know, I can't hear who's talking. Was it you, Fuzzy? You?
That was me. Yeah.
Okay, Angela, how can you have a spondylolisthesis without a spondylolysis?
Because if it slips, or moves, there's not necessarily a breakage often. There could be some imbalance with the ligaments that are connecting it or something wrong with the nucleus.
So you've made a brilliant deduction and you're right. There are different types of spondylolisthesis. One of them is degenerative. One of them, the pedicles are just too long congenitally. Absolutely intact pars interarticularis. But when the disc degenerates, the vertebra wants to slip forward a little bit because that spacer's gone. So if the spacer's gone and it's coming almost bone to bone, sometimes it'll slip forward a little bit. Perfectly intact pars. Good, very good, Angela. Can you have a spondylolysis without a spondylolisthesis? Can you have a bilateral pars fracture without slippage? Yes? Think so?
Seems like it would be tough, but maybe it's possible.
Hmm?
It seems like it would be tough for it not to move, but maybe it's possible.
So you're both right. it's intuitive that if you fracture the vertebra, it ought to slip, right? Because it surely is unstable. Well, guess what? It absolutely is not necessarily unstable, and some people go years when it's first discovered, especially in kids. They'll have serial x-rays as they're followed, because you gotta watch. The longer that kid with the bilateral pars fracture lives, the more likely they are to have a slippage. So you wanna kind of watch it a little bit, surveil it. But many patients will not have a bit of slippage, and this is how that works. When you look at an x-ray, do you see cartilage? Do you see ligaments? Do you see discs? Do you see tendons? Do you see muscles? There's a lot of stuff holding that vertebra together. So it almost kind of looks like it's floating in midair. It's an illusion. We're made, I mean, look at this. If NFL, 300-pound NFL behemoths on the line, offensive and defensive line, can smack together 50 times a game and not have multiple bone fractures, that tells you something about the design of the spine. We are really able to take a licking and keep on ticking. So even though it's completely logical to say that it will, if it's broken, it's surely gonna slip. There's a lot of stuff holding it there. It's amazing how that can happen. So yeah, you can have one without the other, both ways. You can have a spondylolysis without spondylolisthesis, and you can have a spondylolisthesis without spondylolysis. You're probably now more knowledgeable than 70% of doctors practicing in the field. How do I know? Because I've taught since 1992 imaging in trauma to doctors at conventions. And I ask this question, and you'd be amazed how I'm amazed. That's one of the reasons I emphasize this and spend almost the whole morning talking about this kind of stuff, because you can have one without the other. All right. Just know, I think I use either Yoakum, which is a board reference, or Hoppenfeld, which is another board reference, or maybe they're the same in terms of what they say, but L5 is the most commonly involved vertebra for spondylolysis and spondylolisthesis. Second most common L4. And that's so borne out in my 34 years of traveling in the trenches. You can enjoy this. I kind of, some folks are very visual, so I got a pretty little photo. I think this comes out of Netter for you, or maybe it's Hoppenfeld. I think it's Hoppenfeld, but you can see, it just shows you where stuff happens and how it happens. You've heard of the Scotty dog, or if you haven't yet, you will in radiology. It's because that looks like a little Scotty dog, and he's got a collar here. It's a spondylolysis. So there's a way of grading this. The most common way that we encounter, it's called the Meyerding classification, and it's simply this. You divide the base of the sacrum into 4 equal parts, each one of them worth 25%, and the index is the back of the L5. So if I were to draw a straight line down the back of L5 and see where it hits the sacrum, that would be, it's a grade 1 or a grade 2 or a grade 3 or grade 4. I don't need to get into too much detail about that. What would this be? What would your guess be? Here's the Meyerding. What do you think?
Grade 2.
It's kind of like a 2, isn't it? I'd call that a 2. I'd call that a low grade 2.
Question on a grade 2, do you still have to have surgery on it?
No.
Okay.
Nope.
When do you have surgery, 3 and 4?
You might not need surgery for 3 and 4. Yeah. I mean, it depends. You'll hear me say a lot. It depends. I don't speak in absolutes a lot. I've seen people with really, really bad spondylolisthesis, and we tracked them, and they were having pain elsewhere. It wasn't their pain generator. We found out about it what we call fortuitously, which means we x-rayed their pelvis for their hips and see this on the oblique view. We see a spondylolisthesis. Yeah, so they're more likely to need surgery with the higher grade ones.
Okay.
If somebody gets out in a 3 to 4 range, I'm sending them to a spine surgeon just for a second set of eyes on it. But if they're not hurting, the reason fusion works is because it stops movement. And if it's not moving, it's not gonna hurt. If you have a sprained elbow and you just put it in a cast, if I stuck your elbow in a cast, you'd think it's miraculous. My elbow doesn't hurt anymore, but movement is life to joints. So, I'm illustrating that with the absurdity, but if it's not, so they fuse it, hardware. Pedicle screws, and plates, and all manner of hardware. This is something I wanted you to see. Very counterintuitive, comes out of Neurosurgical Journal, and it's relatively recent. It's from, 2015. They discovered there's no association between back pain and spondylolysis with or without isthmic spondylolisthesis. So I just want you to see that association does not equal causation. And if folks disagree with you, we'll refer them to the Department of Neurosurgery at the University of Texas Health Science Center in San Antonio, because these are the people that work on that all day long. They have some authority. I would listen to them, and I do. Can be a pain generator, but that casts a lot of doubt on that. I've had a lot of patients that had advanced spondylolisthesis that I've had only a few require surgery that I referred for, but I've had a few come back post-op, status post L5S1 fusion. Unfortunately, that was not the pain generator. Now, this is not because surgeons are bad people or crooks or liars. They do their best. There's no guarantees, right? Just like you and I, we cannot guarantee a patient a cure. We can just say it's logical, you're hurting, nothing else has worked. You willing to try this? There are risks and benefits, and sign all the papers. They don't like it any more than we would if we have a bad result, but bad results happen. And I've seen them post-op, and of course, am I gonna manipulate L5S1 after it's fused? You sure? You're right, because there's no joint to manipulate, right? What am I gonna move? There's nothing to move. So it's 10 till, oh gosh. So let's go ahead and take, I'll see you back at what time do you have? I don't see a